Around 20% of the Australian population resides in a regional or rural community. On average, those who live in rural communities of Australia tend to be more susceptible to lifestyle diseases such as cardiovascular disease, diabetes, and respiratory illness than those living in metropolitan areas. This is often attributed to people from these regions being disadvantaged in relation to education and employment opportunities, as well as having restricted access to healthcare services. Government reports define remoteness in 5 areas: major cities, inner regional, outer regional, remote, and very remote. Based on these reports, the term rural communities covers all areas outside Australia's major cities. Therefore, the population within this group being described in this report are those who live in one of the 4 areas defined, particularly inner regional, remote, and very remote groups from ages 0 to 85. Rural and urban disparities in health show that due to the prevalence of lower socioeconomic factors within these communities, as of 2015, the total disease burden rate in remote and very remote areas was 1.4 times as high as major cities. This can be attributed to people from these regions generally having a lower socioeconomic status and overall disadvantages in terms of social determinant factors, such as lower education, employment, and income than Australians living in major cities. Rural populations were 53% less likely to eat recommended fruit and veg serves per day compared to 48% in major cities. Alcohol consumption rates were between 19 and 25% compared to 15% in major cities. Obesity rates in these regions were a staggering 70 to 71% compared to major cities at 65%, and smoking rates were between 17 and 20% compared to 13% in major cities. These factors and statistics contribute to higher mortality and illness rates from preventable lifestyle diseases. And despite their overwhelming increased burdens on these communities, there are huge disparities in access to health professionals and services. With little to no access to crucial services and an institutionalized normality of higher smoking, drinking, and unhealthy habit rates, preventable lifestyle diseases are too often prevalent within these communities. Health inequities play a huge role in the increased rates of lifestyle disease in rural areas. There is a complex interplay between health and welfare, where social factors such as an individual's education, employment, and relationships can impact their overall health. The prevalent social determinants of this issue range from lower levels of education, higher unemployment rates, and most significantly, decreased access to health services. The astounding disparities in doctors and facilities available in rural communities compared to major cities is highly problematic. And even with this disparity in healthcare services, rural populations are being hospitalized or contract preventable lifestyle diseases at a far higher rate than metropolitan counterparts. For example, females in rural zones have a rate of hospitalization for diabetes that is 25% higher than females in metropolitan areas. Gender as a social factor also plays a significant role in disparities within this issue. Research shows that around 39% of those living in rural areas have a lower socioeconomic status, which attributes to the increased barriers to accessing health promotion and seeking help for behaviour change. 2 main factors that contribute to this issue are geographic location and lack of healthcare services. Despite more than 30% of the population being situated in rural or remote areas, people often have to travel twice as far to receive treatment or preventative services, further adding to the increased levels of lifestyle-related disease prevalence in these regions. Per 100,000 patients, just 249 treatment centres, from GPs to hospitals, were in reach for inner regional patients, 222 for outer regional, and 239 for both remote and very remote areas, in comparison to 439 in metropolitan areas. These areas are often highly populated with Aboriginal and Torres Strait Islander people who have significantly lower levels of usage of Medicare benefits and pharmaceutical benefits due to lack of education. These barriers are part of the social and economic conditions such as shortages of GPs and specialist services. The healthcare workers in these communities are often made to work longer hours, taking on tasks outside of their normal services to accommodate to the lack of service, impacting intervention on lifestyles for preventable diseases. These two major factors impede on behavioural change as they significantly disadvantage rural communities from the beginning in ways allowing the continued conformity to societal norms that result in lifestyle diseases. Governments are giving higher priority to health promotion in Australia, particularly in rural areas, as they are most at risk of chronic disease. One relatively new intervention is the Commonwealth-funded Healthy Communities Initiative, which aims to promote healthy lifestyles at local government levels to decrease the prevalence rates of lifestyle-related diseases within their communities. Despite the influx of supposed funding by the government, lower socioeconomic status communities in rural areas make these intervention programs complex to implement, as they conjunctively need to address the eradication of poverty, chronic unemployment, and see an improvement of educational opportunities, housing, and public transport. The complexity of this issue arises from years of disparity between metropolitan services and the lack thereof of rural communities. The burdens of social factors that have consequently impacted the overall health of rural communities have become far too prevalent, despite the simple measures that can be put in place to prevent these highly preventable diseases. It seems that the best way to address this issue may be to take a closer look at the individual and societal social determinants that dominate the lives of rural populations, but also to implement more healthcare services and relieve the strain that many healthcare workers here are under. This, in conjunction with more local government intervention programs that rather seek to educate populations and create more behavioural changes than just treat these diseases, could see better overall health for rural and remote residents.